diagnosis, and that too advanced HER2 positive metastatic breast cancer. Actually, it is not only devastating for the patient, it's actually devastating for the entire family. The challenges which this patient face, they are not only physical, they are psychological, they are spiritual, and above all, they are financial. So the topic today is the recent advances in management of HER2 positive metastatic breast cancer. Where are we in 2023? So I will be covering this presentation in this 6 broad heading. So first of all, introduction, then what is the unmet need of the second line onwards, HER2 positive metastatic breast cancer, the recent advances in HER2 positive metastatic breast cancer, transdermal deruxtecan, neratinib, tucatinib, margetuximab. These are the latest molecules which have come to our hands right now. We can maximize the longevity of life and add productivity to the life of the patients by using these drugs in sequentially. What are the current regimen or treatment algorithms for HER2 positive metastatic breast cancer and future consideration of HER2 positive or HER2 low metastatic breast cancer? What is this HER2 low also we'll be covering. So we know that HER2 positive breast cancer is an aggressive disease. The breast cancer is most frequently diagnosed cancer and leading cause of cancer-related death among women worldwide. Approximately 30% of all breast cancer cases will become metastatic after diagnosis, and most breast cancer deaths are due to metastatic disease. HER2 positive breast cancer cells are associated with aggressive disease that is more likely to metastasize. And around 15 to 20%, that is 1 out of 5 patients of invasive breast cancer cases are HER2 positive, defined by high expression of protein, that is IHC3+, by IHC or IHC2 with FISH positivity, or with HER2 gene amplification by ISH. So by and large, if you see, triple negative breast cancer will be around 13.3%. Those patients who are HR positive, HER2 negative, by and large, this is the major subset, that is 65.9%. And if we see HER2 positive and HR positive, that is triple positive, the subset is 13.3%. And if we add HER2 positive and HR negative, it will be 20.7%. So by and large, 1 in 5 patients will be HER2 positive. This is what we have to remember. So there are a few discoveries which have shaken the foundation of cancer treatment, like the discovery of human epidermal growth factor receptor 2, that is oncogene. This is a HER2 overexpression confers the aggressive tumor behavior, but also is an opportunity to the targeted therapies. So there is an unmet need for HER2 positive metastatic breast cancer. So why there is an unmet need? As HER2 targeted treatment options continue to expand, the physicians will weigh many factors when sequencing this treatment. So more than 1/3 of the patients will not receive subsequent therapies after second-line treatment and may miss an opportunity to receive the highly effective anti-HER2 targeted agents if not prioritized for the early use. That's why we have to use the best drugs upfront in the battlefield. The first-line metastatic cancer, so if we have given the first agents correctly, only 78% of the patients will receive second-line anti-HER2 agents. That means what? That means 22% of the patients do not receive second-line therapies. And if the patients are able to afford, or if the patient is having physical fitness for second-line treatment, 65% of the patients will be able to receive the third-line treatment. And that means what? That means 35% of the patients will not be able to receive the third-line therapies. That is why there is unmet need to find out the correct agents, and we have to sequence effectively to maximize the longevity of life within limitation of science. The sequencing decision depends on the previously administered therapies, the progression-free intervals, the sites of progression, the tumor burden, the patient's preference, quality of life, and how was the patient's tolerance in the previous lines. That will throw light that how much aggressive we can be in subsequent lines. So as far as key data supporting the existing therapies in metastatic breast cancer, where are we? So we know that for past 1 decade nearly now, Cleopatra trial, which is the landmark trial for first-line therapies in which THP, that is trastuzumab, pertuzumab, and herceptin, we are using, which are competing with TH. And we know that objective response rate is 80%, and the delta advantage, that is median PFS delta advantage, is 6.3 months. That is 18.5 vis-a-vis 12.4 months with the competitor arm. And the median overall survival benefit is the delta advantage or the leverage is 16.3 months. As you can see, the median overall survival is 56.5 versus 40.8 months, and the hazard ratio is statistically significant. That is 0.68. Then second-line therapies, the Amelia trial is the landmark trial in which TDM1 is compared with the competitors capecitabine and lapatinib, and the objective response rate is 44%, vis-a-vis 31% with the competitor arm. The median PFS is 9.6 months, and it is at 6.4 months with the competitor arm. The median delta advantage of oral survival is 5.8 months. So median PFS drops down by approximately half, that is 50%, moving from first line to the second line TDM1, right? So this is the reason why we have to use this drugs more effectively. So there is evidence suggests that the PFS outcomes of second line TDM1 are worse in patients who receive prior pertuzumab. As I already mentioned, the first line trial we are using trastuzumab doublet anti-HER2 agents, trastuzumab and pertuzumab. But if we have exposed the patient to the first line pertuzumab, the second line TDM1 when we are using, it have shown that the PFS outcomes are worse. So that's the reason there are so many trials which have proven that there are two large real-world Italian studies evaluate second-line TDM1 from pertuzumab exposed versus naive population and reported that there is significantly worse median PFS outcomes. And conflicting median also results are also there, because of which we have to be skeptical. We have to think twice before using that drug in the second line. There is a reduced outcome of TDM1 after prior to pertuzumab, maybe due to reduced HER2 expression. The further supporting the impact of HER2 expression on TDM1 effectiveness are data from post-hoc analysis of Marianne study. We all know that the patients with heterogeneous, that is 30 to 79% of IC2 plus or 3 plus tumor cells versus homogeneous HER2 expression, that is greater than 80%, achieved a shorter median PFS with first line TDM1, that is 8.3 versus 14.7 respectively in months. So recent advance in HER2 positive. So where are we? We are having multiple drugs right now. We are having trastuzumab deruxtecan, which is a new drug which have come into the market. Then tyrosine kinase inhibitor like niraparib, tucatinib, margetuximab. These are the latest molecules which have come. So there have been an unprecedented flourishing of anti-HER2 agents over a period of time. So in 2019, trastuzumab deruxtecan data coming, the Destiny Breast trials, Destiny Breast 02, Destiny Breast 03. Now for HER2 low setting also, we are having Destiny Breast 04 also now. Trastuzumab kinase inhibitor, niraparib, tucatinib. They are the oral pills which are available. Margetuximab is the latest molecule in 2020, and these are the drugs. So if I tell that we are living in a golden era of advanced metastatic HER2 positive breast cancer, I don't think it's an overstatement. There are many drugs in first line. There are much more drugs in second line. There are many more drugs in the pipeline which are going to come in next couple of years. So one by one I'll be touching because of the limitation of time. Trastuzumab deruxtecan. It's a highly potent topoisomerase-1 inhibitor, which is there is a payload, there is a cleaver linkage, there is 8:1 ratio of drug to antibody ratio. Trastuzumab deruxtecan demonstrated a response to therapies in 60.9% pre-treated patient population with HER2 positive metastatic breast cancer. Both these molecules are antibody drug conjugates. So what's the difference between that? So there is a payload mechanism which is different. The payload in trastuzumab deruxtecan is topoisomerase-1 inhibitor, and in TDM1 it is anti-microtubule. Antibody drug ratio, the drug to antibody ratio is 8:1 in trastuzumab deruxtecan. It is 3.5:1 for TDM1. There is a tumor selective cleavage linker which is present for trastuzumab deruxtecan. It is not present for TDM1, and there is evidence of a bystander anti-tumor effect for trastuzumab deruxtecan. There is no bystander anti-tumor effect for TDM1. So because of this 8:1 ratio of drug to antibody ratio, the more of the drug will be internalized in the cancer cells and will get the benefit. So first trial was Destiny Breast 02, which was a phase 3 open label multi-center trial in which trastuzumab deruxtecan was used at the dose of 5.4 milligram per kg Q3 weekly. It was a 2:1 randomization, and the patients were having centrally confirmed HER2 positive by IC3 plus or FISH positive IC2 plus unresectable metastatic breast cancer who are having a documented radiographic progression after most recent treatment, and previously they were treated with TDM1. So risk stratification was done based on the hormone receptor, prior treatment with pertuzumab, and any history of visceral disease. The median, the primary endpoint was median PFS by blinded independent central review. The key secondary endpoints were median overall survival. The other secondary endpoints were objective response rate, duration response, PFS, safety, and exploratory endpoints were the complete benefit rate and PFS2. So what they highlight, both the treatment arms were equally balanced, and majority of patients were IHC 3 plus, and 19%. That's 1 out of 5 patients were IHC 2 plus and FISH positive. And there are 58% of patients who are hormone receptor positive also, and 18% of patients were having brain mets at baseline, and around 22% of patients were not having visceral disease, and 77% of patients were having visceral disease upfront. So majority of the patients have already received prior 2 lines or 3 lines of treatment before enrolling, and 78.3% of patients have been exposed to pertuzumab. This is a very, very key highlight feature of this trial. What was the median PFS? The median PFS was 17.8 months with transformer deruxtecan, hazard ratio of 0.35 as compared to the treatment of physician choice. And as you can see, the Kaplan-Meier were wide apart. What about the oral survival? Oral survival in Destiny-02 also was 39.2 months. Hazard ratio was statistically significant. As we know that lesser the hazard ratio, better is the experimental arm. It was 0.65 in oral survival also. So exploratory endpoints also were all met. So main conclusion which I want to draw because of limitation of time, that Destiny-02 transformer deruxtecan demonstrated statistically significant and clinically meaningful improvement in PFS, OS versus treatment of physician choice. And the overall safety profile was consistent with the established safety of transformer deruxtecan with no new safety signal observed. Then came Destiny-03 trial. This is the main trial because of which transformer deruxtecan is approved now. Open label multi-center phase 3 trial in which it is a 1:1 randomization of trastuzumab with TDM1. The competitor was TDM1. The primary endpoint of this trial was PFS. The key secondary endpoints were mid-overall survival, and the secondary endpoints were objective response rate, duration of response, PFS, safety. And what the most important thing which I have to highlight is 57% of patients were from Asian countries. Brain mets, 23.8% of patients were brain mets upfront. And there are visceral disease was present in 70.5% of the patient. 60% of patients in each arm received prior trastuzumab, which we have to highlight. And the primary endpoint was PFS by blinded independent central review. The median PFS was not reached. The 12 months PFS rate was 75.8%, and the hazard ratio was 0.28. Look at the hazard ratio, 0.28. That means it is statistically significant and obviously clinically meaningful, as the Kaplan-Meier were wide apart. The PFS, all the variables in whether the hormone receptor was positive or not, whether prior pertuzumab was given or not, visceral disease was present or not, number of prior cycles, history of brain mets at baseline, all, as you can see, the forest plot, all the dots are on the right side of line of unity favoring transformer deruxtecan. Updated primary endpoint, that is PFS, rest is 28.8 months, hazard ratio 0.33, favoring transformer deruxtecan. Key secondary endpoint, 74% reduction in progression or death, and hazard ratio 0.26, and median PFS is 25.1 months. That's why this drug is amazing drug as far as advanced HER2 positive metastatic breast cancers are concerned. So I will come to the most important part of this trial. Safety part, this is much more tolerable, although there are some side effects which are likely to happen, like pneumonitis or interstitial lung disease or thrombocytopenia is very commonly seen with TDM1. So the most common side effect was anemia, thrombocytopenia, and decreased blood count, other than nausea and vomiting, which are all manageable. Fatigue was seen in 5.8% patient, and neutrophil count was decreasing 16% of the patient with transformer deruxtecan. Key highlight feature as a side effect, we always have to remember interstitial lung disease. Grade 3 are very less, only grade 1, grade 2 majority of patients were having. ESMO 2022 updates, the time to definite deterioration in patient-reported outcome measures were numerically prolonged with transformer deruxtecan. The most important conclusion is that transformer deruxtecan demonstrated a clinically meaningful and a statistically significant improvement in the overall survival over TDM1, as well as continued PFS benefit in patients previously treated with trastuzumab and taxane. The consistent overall survival benefit was observed across key subgroups, and with longer treatment duration, transformer deruxtecan continues to demonstrate a manageable and tolerable safety profile. Okay, I will just quickly come to just briefly. I will touch this tucatinib. There is a HER2 climb study. There also is a positive study. Only criticism about the choice of control arm may be inappropriate. Transformer capecitabine is not fair competitor. An ideal control arm should be capecitabine labatinib versus capecitabine labatinib and trastuzumab. So with the limitation of time, I will not go in deep. I will just come to this most important slide. In first line option, we are having pertuzumab, trastuzumab, and docetaxel, and the other option is pertuzumab, trastuzumab, and paclitaxel. Second line now, transformer deruxtecan is the option with TDM1. Third line option, there are multiple options right now. Tucatinib, trastuzumab, and capecitabine is the category 1 recommendation. Transformer deruxtecan can be used in third line also. Capecitabine, trastuzumab, and labatinib. You can use niratinib, capecitabine, margetuximab, and plus chemotherapy is also a viable option. It also come in ESMO guidelines right now, and HER2 low also is a late concept. So we have to do a biopsy from the progressive site and confirm the HER2 status. If it is HER2 2+ or 3+, obviously we have to give these agents in future. So take home messages: between first line THP and second line TDM1 treatment, the median PFS drops numerically by half, demonstrating that more effective treatment